Welcome back. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Professor AbdelAzeim Elhefny, Professor of Internal Medicine, Rheumatology and Immunology. This is part 3 in Systemic Lupus Erythematosus lecture. In the last two parts, we discussed lupus definition, epidemiology, classification criteria, and the clinical picture. This is the ILOs of the lecture if you want to revise. Investigations of a case of lupus. First of all, we do very simple test, which is the complete blood count. There is leukopenia and or anemia in lupus patients. The possible cause of leukopenia in lupus is immune destruction, marrow suppression, hypersplenism, or some drugs. The possible cause of anemia in lupus patients are either autoimmune hemolytic anemia, anemia of chronic disease, marrow suppression, blood losses from thrombocytopenia, or the use of nonsteroidal anti-inflammatory drugs, or also hypersplenism, and anemia of renal failure if the patient got this. Thrombocytopenia in SLE patient, it may be modest when the platelet count is from 50,000 to 100,000 per cubic millimeter. It is in this case chronic and asymptomatic, or profound thrombocytopenia if the platelet count is less than 20,000 per cubic millimeter, and in this situation it will be acute with gum bleeding, petechiae, and other complications of bleeding. Thrombocytopenia in SLE patient has multiple potential causes, including ITP, idiopathic thrombocytopenic purpura, antiphospholipid syndrome, thrombotic thrombocytopenic purpura, and active disease. Any young female presenting with idiopathic thrombocytopenia should be evaluated for SLE. Fortunately, there are rarely qualitative defects in the platelets, and therefore life-threatening bleeding is unusual. The serological test to aid in the diagnosis of lupus, antibodies and its clinical features. ANA, anti-nuclear antibody, is very frequent and used as a screening test for diagnosis of lupus. The frequency is more than 90%. It may reach 98 or 99% of cases. When a patient with manifestations like lupus and we asked for ANA and the test was negative, it is very rare and usually causing some question marks. But it is non-specific and only for diagnostic purposes as a screening test. So we did not follow the level of ANA for monitoring the disease. It is only for diagnosing and screening the patient. Anti-double-strand DNA, it may be present in about 60% of cases, and it is specific and usually associated with nephritis and with disease flare. Anti-RNB present in 30 to 40% of cases and associated with Raynaud's and musculoskeletal manifestation. Anti-ribosomal P antibody present in some cases up to 10 to 20% of cases and associated with CNS psychosis or major depressive illness in lupus patient. Anti-SSA or low anti-Rho antibody present in about 30 to 45% of cases and associated with dry eye and mouth, associated with subacute cutaneous lupus, neonatal lupus, and photosensitivity. Anti-SSA, SSB, or anti-LA antibody is present in 10 to 15% and also associated with the same manifestations like anti-Rho. Antiphospholipid antibodies present in about a third of cases and associated with clotting diastasis in these cases. Lupus nephritis. Lupus nephritis is a fearable and serious manifestation in lupus patient, and one of the most causes of deaths usually arises within 5 years of diagnosis. It increases the mortality and the morbidity in lupus patient and considered as independent factor for early atherosclerosis. It is more severe in blacks than in white persons and more in men than in women. Manifestations of lupus nephritis usually urinary sediments more than or equal to 5 red blood cells per high power field or urinary casts, urine protein excretion more than half gram per day or more than 3 plusses on dipstick, and elevated serum creatinine equal or more than 1.5 milligram per deciliter. Symptoms related to active nephritis include peripheral edema secondary to hypertension, hypoalbuminemia due to heavy proteinuria, or cardiac decompensation. Indications for renal biopsy in lupus nephritis patients: number one, increasing serum creatinine without alternative causes such as sepsis, hypovolemia, or medications. Confirmed proteinuria of more than 1 gram per day, either 24-hour urinary specimen or spot protein creatinine ratio are acceptable. Combination of the following: proteinuria more than half gram per day plus hematuria or cellular CAS in urine. One of these indications are sufficient to ask for renal biopsy to diagnose lupus nephritis, because it is very important to diagnose it early and to treat it early to avoid renal failure. WHO classification of lupus nephritis: there are 6 classes. Class 1, minimal mesangial glomerulonephritis. Class 2, mesangial proliferative glomerulonephritis. And these two classes, the patients are usually asymptomatic and did not need any treatment for the kidney. Class 3, focal proliferative nephritis. Class 4, diffuse proliferative nephritis. And these two classes are more serious and requires early diagnosis and meticulous and aggressive treatment to prevent further morbidity and mortality. Membranous nephritis, causing signs of isolated nephrotic syndrome with heavy proteinuria and hypoalbuminemia and edema. Class 6, glomerulosclerosis, leading to end-stage renal disease. Patients with active lupus nephritis have other symptoms of active lupus, including fatigue, fever, skin rash, arthritis, sinusitis, or CNS disease, especially in class 3 and 4. Estimated glomerular filtration rate 60 milli per minute per 1.7 meter square, or creatinine clearance 1.5, is a risk factor for accelerated atherosclerosis, and this is very important to diagnose and monitor. These are the pictures of some classes of lupus nephritis. Now, lupus and pregnancy in lupus patient is very crucial because, as we said before, it affects the females mainly in their reproductive age. So, most of the lupus patients will ask you about how can you help me to get pregnancy. Lupus does not affect fertility, but SLE pregnancy outcomes are more likely to be complicated. For the mother, pregnancy may cause SLE exacerbation, lupus nephritis, preeclampsia, possible need for preterm delivery, and an increased rate of cesarean section. For the fetus and neonate concern, miscarriage and fetal death, premature delivery, and preeclampsia, placental insufficiency, and intrauterine growth retardation, all these factors are fetal and neonatal concerns due to lupus and also its complications, and the neonatal lupus can be transmitted to the fetus. Patients should avoid pregnancy in the presence of active lupus nephritis, severe hypertension, serum creatinine equal or more than 1.5 or maximally 2 milligram per deciliter, or proteinuria equal or more than 1 gram per deciliter. So, lupus and pregnancy are enemies. Lupus can be a risk factor to pregnancy because of pregnancy losses, preterm delivery, eclampsia, preeclampsia, neonatal lupus due to anti-Ro antibodies. And also there is risk of pregnancy to lupus causing lupus flare, progressive renal disease, maternal thromboembolism. Pregnancy and lupus may end in neonatal lupus. Neonatal lupus is a rare syndrome associated with maternal antibodies to anti-Ro SSA or anti-La SSB in about 7% of cases. Infants develop erythematous macules or papules and exacerbated by sun shortly after birth. The lesions typically resolve without scarring, but dyspigmentation and telangiectasia may occur. This is the erythematous rash in neonate. Some infants may develop hemolytic anemia, thrombocytopenia, leukopenia, and hepatosplenomegaly. Complete heart block may occur and needs pacemaker, and may lead to congestive heart failure, even sudden death in some cases. Very few infants with neonatal lupus develop SLE later on in life. There is about 25% risk for subsequent pregnancies to be affected, and this is considered as high risk group. Complications of lupus. It may be disease related like cardiovascular complication, end-stage renal disease from lupus nephritis if untreated, cerebrovascular strokes, hypercoagulability with thrombosis, and cytopenia due to disease flare or due to, as we said, treatment related complications. Infections due to immunosuppression, coccinioid and styrobra due to corticosteroid, cytopenias due to bone marrow depression by cytotoxic drugs, bladder toxicity especially due to endoxan infusion, cyclophosphamide, premature gonadal failure and infertility after cyclophosphamide use also, repeated courses, premature atherosclerosis due to corticosteroid, increased risk of malignancy in some cases treated with immunosuppressives, osteoporosis due to chronic use of corticosteroid, and avascular necrosis from also. And this MRI shows avascular necrosis of the head and neck of the right femur due to prolonged use of corticosteroid therapy in SLE patient. And this is the end of part 3 of the SLE lecture, and we will follow to the part 4 and 5.